Good afternoon, distinguished guests, lecturer and staff of the Faculty of Medicine, Siriraj Hospital, and honors guests from other universities and hospitals as well. My name is Tasaniya Ratanarutai Noparat Jamjamrat from Siriraj Health Science Education Excellence Center. Together with me is, please introduce yourself.
Good afternoon, everyone. I am Punyapatma Prapo. You can call me Prab, Prab or Prab, Prab like probability. I will be a coordinator with Ajahn Tasaniya or Ajahn Ke today in this session.
Okay. On behalf of the center, we are all here to welcome Associate Professor Satid Thammasitboon and also Associate Professor Diane Nguyen from Baylor College of Medicine in the U.S. to share experiences in the two special learning conversation sessions of POST in medical education, which are assessing clinical listening skills and a practical guide to assessing the value of an educational program through the lens of community of practice. Let me introduce our speakers for a while. Associate Professor Satid Thammasitboon graduated from Prince of Songkhla University with the first class honor. He also received M.H.P.E. from the University of Illinois at Chicago. Currently, he holds the position of Associate Professor in Pediatrics Critical Care at Baylor College of Medicine and also a director of the Center for Research, Innovation, and Scholarship in Medical Education as well. His mentorship has been recognized with the Faculty Development Mentorship Award and Research Mentorship Award. We may learn more about assessment and also mentorship from him after this. The second speaker, Associate Professor Diane Nguyen, received a Doctor of Pharmacy from Massachusetts College of Pharmacy and Health Science. Presently, she is an Associate Director in the Center for Research, Innovation, and Scholarship in Health Professions Education. She will share some experience of working with various people with us today. Before we start, on behalf of the Siriraj Health Science Education Excellence Center, I want to disclaim any conflicts or benefits that might happen during the seminar. It is not our intention to support any commercial materials or any programs. We focus only on the knowledge you might gain from the seminar. We have a big approach for our speakers.
And for a little disclaimer, if you all want to ask questions, but you're comfortable to ask in Thai language, you can also ask and we will translate that for all of you.
Good afternoon, everyone. It's such a pleasure to be here. And we have planned a session to be conversational. So Diane and I, in fact, plan to have more dialogue with you. So please stop at us anytime. We have some slides, but it's more like a security blanket because sometimes it's hard not to present without any slide at all. But we plan not to use too much of. If you don't want to see any slides, just ask a lot of questions. And we look forward to learning from you as much as hopefully you could learn something from us. How's that sound? Okay. I'm gonna excuse myself to speak English because I think I teach better in English. Though, please, as we have discussed that you could just ask in Thai, but not in Myanmar, though. Right? Or you could translate for me. Okay. How many of you work in clinical settings? For those of you that don't work in clinical setting, I assume more like education only. Is that correct? Okay. So I would say that you don't really have to work in clinical setting to gain more insights around clinical reasoning because reasoning is somewhat a universal processes, right? Could be applicable to any setting, but as a health science educators, gaining additional insight about clinical reasoning would help you either in the educational work or research work at time. Can you hear from a couple people why you chose to come to the session today? Okay. I hope then How do you all normally assess clinical reasoning? Let's say you have a trainee, either nursing trainees or paramedic trainee or medical trainee, and they just have seen a patient, right? And they come to present the history and physical exam to you. How can you tell if that's a good presentation or bad presentations? If you pause too long, that means it's in the black box. Anyone? How could you tell it's good or bad? They say, oh, this medical student present the case so badly or so great. Do you mind speaking a little bit louder so others could hear?
I think the good presentation, when I hear the student, it's important that the presentation is systematic and
Systematic, okay?
yeah, it's relevant to the clinical setting that he or them that's assess physical exam or history taking. Yeah, it's
Wonderful. So being systemic could be like by organ system, right? And when you say relevant, it could be like talking about history and physical exam, mean present history and physical exam that relevant to the differential diagnosis, rather than just keep talking about, or the patient have traveled different to see 10 doctor before coming to see you, and you just fall asleep by the time you come to differential, right? What else? Yes, from nursing perspective.
Yes, good afternoon, Ajahn. The diagnosis is very concerned in nursing education as well. In nursing education, we have a nursing diagnosis.
Mhm.
This is the very core competency for the nursing. We call the ADPRE. A is the assessment, D is the diagnosis, and P is the planning, and I is the intervention, and E is evaluation. So before going to the nursing intervention, we have to know about how to assess the patients. Yeah, the history taking and the physical examination, nursing assessment is very important to diagnose correctly. This is the very first beginning and very important point.
Wonderful. So I work in the ICU, right? A lot of time, the conversation with bedside nurses is actually what prompt the better differential. So I'm so glad to see you here, because the nurses contribute significantly to improve diagnosis in the clinical care, right? Anyone else? Yes.
I would keep it simple, like a good explanation from a med student would be something that we understand. Like we listen from them and we know like what's the common complaints and what happened, and anything that gives us a clear idea on how to manage and treat the patient.
Right. So from what I'm hearing you, that you need to be able, when they present the case to you, supervising educator should be able to tell what's going on inside their head, right? Not just go talking about different things and not sure whether it's relevant to the patient or have no idea what they are talking about, right? So clinical reasoning is happen inside the someone head, right? The cognitive system. So that's why I put this picture up, like it's almost like a black box. And different supervising educator, a lot of time they just look at the clinical reasoning more holistically, right? And at time when I ask, oh, let's say if I work with you and you say, oh, this training is really good in critical thinking and critical reasoning, and I talk to Diane say, oh, not so good, right? So a lot of time there's no clear framework or construct to make sure that we are looking at the same thing. Or I'm not saying that they have to be exactly the same thing, but at least there should be some sort of construct. What kind of assessment instruments or tool that you all have used to assess clinical reasoning? To open the black box, short essay.
Now,
Could you explain more what you mean by short essay?
It's like
Patient record?
yeah, some kind like that, Ajahn, and we just give the give the topic to students and let them describe systematically something like that.
Okay.
And we just checked from there, like it can tell us about something. Students, they have something in their mind.
Very good. So written essay about what they have gathered, what they are thinking, differential diagnosis and so forth, right? So you could read their mind. Good idea. What else? Yes.
I'm doing the OSCE, and for written test, we can use key feature questions.
Wonderful. All the key feature or doing the OSCE, right?
In my opinion, it depends on our educational objective and learning outcomes, and we can use non-work-based place assessment. Mostly these are the written assessment, and we can use not only simulated environment like the OSCE or technological enhanced, or even workplace-based assessment like the direct observation or mini section. So we can use the multiple assessment for this clinical reasoning.
Wonderful, wonderful. So I love what you say, but I want to highlight the last point, that using multiple assessment. That's very critical, right? That in line with what I tried to allude to earlier, that when I say this is a good student, Diane might see something different because assessment is very contextual, right? I love all the approaches and tools that you have brought up so far. And I want to start by session today because we want it to be conversational. I'm not going to give lecture on all that, but feel free to access all these references. I try to select a relevant article for you. I hope the QR work. If you want to do a deep dive on multiple instrument exist in literature, it's a little bit old, but not too old, but I could guarantee you that's no recent scoping review on the assessment instrument. Michelle Daniel actually worked with me a lot at Best Evidence Medical Education, and this for exemplar. It's a very long article, so read it as more like manuals, not so much about having to learn everything, because if you look at different form of assessment, this is just snapshot. Actually, the table is much longer. But I want to highlight that the team actually categorized assessment of clinical reasoning into non-workplace-based assessment, workplace-based assessment, and simulated clinical environment. So I think everyone could walk out from this room now because what you listed actually capture most of this. But I want to highlight one thing. What you have listed as example of the approach to use, a lot of time, educators think about non-workplace based assessment or simulated environment assessment. I'm not a big fan of those. Anyone want to guess why? Would you like me to walk around? I feel, but I guarantee I'm not gonna jump like a T-Max, but I just want it to be conversational. That's why I sit down. But let's see if I got more energy to walk around. But why am I not a big fan of non-workplace based assessment?
Because we can assess the real context, and it is just of the part of the clinical assessment, and like the workplace assessment. Yeah,
Right?
we cannot assess the whole situation. Yeah.
Okay.
For me, I believe that the student can express than skills or something in workplace situation
Okay.
more than just
Very good.
classroom or
What else?
simulation.
Yes.
For me, I also prefer this type of question and this type of assessment, like a non-workplace based assessment.
Non-workplace.
Yeah, because in my emergency nursing student life, we have to answer the question based on the scenario, and then we have to analyze the the key reflex signs, and then we have to analyze what is the, for example, the patient present to emergency department with a chest pain. So we have to, and then the questions have some clues like vital signs. So we have to pick up which is for example, the blood pressure and also the pain scale and the pulse rate and appearance, and we have to pick up and trying to analyze.
Okay.
Is this the cardiogenic or something like that? So I think it also provide us to increase our clinical reasoning, I think.
Okay. So what you are saying is that when you do a non-workplace based assessment and or simulation, it might give you more information because you could plan, right?
Yeah.
And also deconstruct the clinical reasoning process that tend to take place naturally and assess more easily. That's a good argument. But I want to hear from someone that would be on my side, that you are a big fan of workplace-based assessment. Anyone? Don't fight, but
He is an author
Good
in this
ahead.
topic.
Okay, but I think at first I agree with the previous agreement that the non-workplace based assessment can give me like a lot of more detail, in-depth detail from the student. But after I look at the detail of the workplace based assessment, there's something like the oral case presentation or maybe the written note or the thing around. I think that kind of thing can can give me both information in the authentic situation and also the in-depth information from what inside the student head. So
great.
maybe this.
Thank you.
Okay,
Thank you. I love what you call by authentic, right? Let me give you an analogy. For those of you that already married, cannot answer. But if you are dating someone on like matching online or something, are you gonna marry someone that you've been just texting or posting Facebook or IG
No.
without going out on a date? It's very risky, right? It's very risky. Why? If even with writing, right, on IG, Facebook, or even email or text, we don't know what's going on. That person might be faking and write something that crap from ChatGPT and put in the text to you, right? The same thing with simulation. How can you tell that the trainee actually would be acting the same way, right? In the simulated learning environments, right? By the way, I'm not saying it's bad because sometimes I don't want to meet person or actually get a phone call. Sometimes my colleague call me, oh, they're so rude calling me, right? It's just text. But when we talk about authentic assessment, right? Especially for clinical reasoning that we already discussed that it's more like a black box, right? Would that be easier just to look at them and ask them to think aloud with you, right? And for those of you that could read small print, by the way, I'm not expect you to see that, but the blue one, right? You could tell already based on this scoping review and all these expert evaluate assessment instrument, they give a lot of blue color, meaning very good for workplace-based assessment. Okay. By the way, but I'm not saying that non-workplace based or simulated environments are bad. But if you want to look at efficiency, rather than texting, doing IG and reading the blog, just go out on the date a couple of times and figure things out, right? Okay. Having said that, that's why the Society to Improve Diagnosis have developed an assessment of reasoning tool, which I led the team. We started by creating this conceptual framework for clinical reasoning in order to inform tool development. Okay. When you look at the big table in the previous slide, there's a lot of assessment tools. The problem with those gigantic amount of assessment tool is that actually each tool assess different things. I think as you pointed out, multiple assessment, that's great, right? You want to assess different aspect of one competence, but at the same time, as a program, as a nursing training program, medical training program, or some other, even though you use multiple instruments and assess different aspects and different time, you want to make sure you have the same language, the same framework as almost like the blueprint of what you see as clinical reasoning, right? So that's why we started from that. We don't have time to go all kind of detail about this step, but it's quite intuitive for those of you that are clinicians, actually. Start by collecting and interpreting clinical information, right? And you have to make sure that, as you pointed out earlier, trainees have to collect relevant information. And in this case, we define that defining feature and discriminating feature. Who can I see the hand who know the differences between the two? Defining feature and discriminating feature. From the back.
Yeah, I'm not sure that I understand it correctly, but I will try. I will guess
You
it.
can guess.
Yeah. I think the defining feature is mean in the medical diagnosis is mean that in a script that define to that particular diagnosis. Something like a pneumonia, we have a cough symptom, we have a fever symptom, we have a lot of sputum, we have a high grade fever, something like that. And the discriminating feature is means the feature that we can use for discriminate the diagnosis to another author's diagnosis, something like if we would like to differentiate the pneumonia from heart failure, the discriminate feature, we should ask about the orthopnea and P&D. I guess I'm not sure that it's correct, but this is my thought.
Excellent,
Thank you.
right? Defining feature could guide us, but discriminating feature would say that is this, not that, right? Orthopnea is discriminating feature of heart failure from pneumonia, right? For pediatrician in the room, a good example would be Koplik spot for measles, right? That discriminating feature. So it's very difficult for trainee actually. So early trainee will just give you a lot of noise, right? But the signal would be defining and discriminating feature. And then with once they present the history and physical, they have to formulate problem representation. Who know what problem representation is? Chief complaint is like when they triage, right? Problem representation would be require more complexity than that. Yes.
I think that the problem representation is like summarizing the defined features and discriminating features in history taking and physical examination, and you also provide your reason why you think those like the provisional like the differential diagnosis, and
Very
you
good.
present it. Yes.
Excellent. I would then know I'm very picky about words. All correct, but I would recommend that instead of summarizing, change that word to synthesizing. Because summarizing, sometimes students still restating the sign and symptom. But problem representation is have to be synthesized and concise and give you the sense. For example, if medical student present the case and say the problem representation is this, you would know right away. Let's say if you're on call for like, they are technically on call at home, right? Okay. You are attending on call at home and you hear problem representation, you need to know whether you have to come in, drive in immediately or just go finish your Korean series and then drive in to see the patient, right? So problem representation have to capture the essence of the patient and let you know what exactly going on, and also guides to some differential diagnosis that come later, right? I don't think we have time to go through the detail about recognizing pattern and formulate illness script. There's a robust literature around that. It would take another hour to talk about it. But if you go to the article and read more about illness scripts, I think it's the essence of clinical expertise. And then the student would have to present to you, or I think it's pneumonia and not heart failure, but it could be just high fever or something like DKA too, right? Patient breathing fast because of Kussmaul breathing or something, right? And then the issue with early trainee is that they have differential diagnosis, have working diagnosis, then they just stop there. It is critical for the supervisor to ask them to engage in metacognition. Who have heard of this term metacognition? Many people who have not answered, maybe that person have to answer. Metacognition. Because so far we talk about cognition, right? What happened inside our head? Who want to try? You answer too many questions already. So let's give to someone else. Let's go to the back again.
For the metacognition, I think it's mean the student can know what can acknowledge and can recognize what is their thought go on. They know that why they think this, why they can discriminate this symptom from another symptom, and what is they can recognize of that cognitive process.
Okay, great. So metacognition is thinking about thinking, right? But what you describe probably capture some metacognition, but not so meta, maybe half meta, right? Because what you describe still more like thinking aloud. When you are thinking aloud, a lot of trainee would continue to stick at cognitive level. So a good example about metacognition would be, here was I cognitively, right? Thinking about differential diagnosis, all that. I think this patient probably just have UTI, right? But this is a teenager, could be sexually active. But I know this patient from the very young age. I might feel like I still treat this child as a child, right? Is that possible that this abdominal pain is actually ectopic pregnancy, right? That thinking about one own thinking, that I might have bias because I feel like I see this teenager a child still, right? Or another good example would be cancer. When we have relationship with a patient, we don't want our patient to have cancer, right? Also, this type of thinking, and also when the trainee actually take perspective of others, right? Of patient, of the family member, and think that, oh, I got the sense that the information that I have been receiving probably accurate, but might not be as precise. I sense for some reason, I sense that there's some hidden information there that perhaps I need to ask the parents to the pediatrician, or keep coming back to pediatric cases, but ask parents to step away so I could talk to the patient myself or something like that, right? This metacognition is not ingrained in most training. So it's very critical for supervisor to actually pause and actually ask probing questions, such as, is anything else in your mind that might be going on, right? Psychosocial issue or something that you feel uneasy about, right? Is that possible that your relationship with the patient might have biased your thinking or something like that, right? Question. Okay.
In Thai context, sometimes there is so many patients that we see like per day or per half of a day. Sometimes we have to rush through like the diagnosis and treatment plan. We might go like throughout the day, but we will like have some bookmark on some patient that we think there's something actually wrong on that, but we don't have time to actually explore on that, but we like bookmark or we have like some early appointment. Would that also consider like metacognition if we don't actually
Thank
do
you
something?
for bringing that point. Is right. At the same time, I would say that it have to be routine in the way that any diagnosis should not be a definitive diagnosis. I teach my trainee all the time, whatever differential diagnosis or diagnosis that you finally decide to manage the patient is not the end, right? You always to think of the possibility that that might be either just one of the diagnoses that actually lead to something else, right? Think about diagnosis at working diagnosis at all time would help reduce diagnostic errors, right? Thank you. Any others? Let me ask you, does this conceptual framework resonate with you, or would you like to add anything else that you could say that all this society they just they miss a lot of stuff? Anything else that you think would like to add in your practice from nursing perspective?
Well, I would like to interpret like emergency aspect. In emergency department, we when we do the triage, there is a two assessment: the primary survey and secondary survey. So I'm just compare with this situation. So we have to collect the data and then trying to interpret what's going on, and then for as a triage nurse, we have to send the patients to the right place to get right treatment. So in right time. So we have to analyze, and then sometimes it's difficult to decide which department we have to send, medical or surgical, something like that. So and then after considering some diagnosis, but we have to recheck in the, for before 5 direct evaluation. We have to check the like a secondary survey, ABCD or something like that.
Thank you. Great insight. Some of you probably missed the nuances there. Let me step back. Even though we talk about, I have been using the term clinical reasoning all this time, right? If you explore clinical reasoning literature, majority of the literature talk about actually diagnostic reasoning, right? What you point out actually capture the two other components of clinical reasoning that just emerging. For those of you that attend the TMEC, David Cook, who have done a lot of work about clinical reasoning, actually more like research in general, but his focus area right now is on management reasoning. So let me give you the new construct now for clinical reasoning. There are 3 parts, actually 2, but I have hidden gem, the 3rd part that you just mentioned. Clinical reasoning comprises of diagnostic reasoning that have been studied extensively, including this. If you go to read this paper, I purposefully use the term diagnostic reasoning at all time, not clinical reasoning. The new emerging area now is management reasoning. That you point out, when you triage the patient in the emergency department, right? You need to know, oh, this patient so sick, I have to manage this patient right away. So have to go to do we call trauma room? Yeah. Rather than just waiting and sipping tea, right? That's important. Another part that my hidden gem that is emerging, but it's my secret right now, is prognostic reasoning. That you point out, in order for you to triage the patient to the right room, require prognostic reasoning. The construct of prognostic reasoning is being researched right now. If anyone want to be famous, do it right now. Okay. So step aside. That thank you so much for that, because that is critical for us to be mindful that what we are talking right now actually is diagnostic reasoning. Okay. For those of you at TMEC, you probably got the sense, right? That David Cook actually still struggle with it. So when we use this conceptual framework to inform our tool. For those of you that check the QR code, this actually inside that article. It's an open access, right? I'm gonna, for those of you have not cheated and look at the QR code, I want to pause here briefly for you to just kind of skim through it. We're not gonna go into the detail because it's something that you could study on your own. So in a workshop or my teaching session, this will be the time that I show you a video of resident presenting the patient to the attending and ask you to use this rubric to assess that performance, right? But we don't have time for the video. Looking through this, just skim through this assessment tool, do you think you could use the tool, or there's what would be the some comment or critique about using the tool in the term of practicality or whether it's difficult to use or easy to use? Any concern at all?
I'm thinking of some scenario that I think it's very easy to use. It's just like 3 checklists.
To say that in front of me, but
but sometimes in most of my clinical work, I'm doing a lot of ER shift, emergency department. Sometimes we just like don't go through all this. We see like vital sign and then we do something and then we just like thinking of what's going on because there is no patient cannot talk to you. Their relative or the people who see the scene might follow you after and you have to do whatever you think is like possible there, and we cannot assess any of these using this rubric. So I think for some emergency condition, this might kind of like not in a situation where we can get the best.
So sometimes we just have to do the snapshot of some of the domains, right? Not at all time. Thank you. What else? You probably could guess that they asked this question because I know that the tool is not perfect. Yes.
Yes, I would like to add on from Ajahn Pap that there are scenarios in real case scenarios that we might not be able to fully assess this. And it's because of the time and the workload. And also like just from the first criteria on collecting report history and examination data in a hypothesis directed manner, I think from this one, after I read this, the immediate scenario I was thinking of was like, if you see a patient coming in with stomach ache, and then to have good reasoning, you must not ask guiding questions, right? But really in real-time scenarios, when we ask the patient like, how is your stomach ache like? And then sometimes they can't have a clear image of what the pain is like themselves. So sometimes we have to ask like, so is the pain piercing or dull or something like that?
Thank you. That's an excellent point, not to ask leading question, right? I think, how many of you that have been clinician for more than a decade, more than 10 years? 20 years here. Chan Chersak cannot answer this question because he's been practicing. Do you really don't ask leading questions? No, right? So I think this point is very critical for early trainee or medical student that, don't ask leading question. But in fact, why wouldn't we teach them the same way and to do and to think like how experts do, right? Actually, there's research evidence to show that clinicians who think about diagnosis or differential diagnosis at the beginning when they hear chief complaint after all said and done, the final diagnosis were more accurate, right? So is it very, I think go back to your point earlier, the information have to be relevant, right? But to the point about not asking leading question, in fact, it should be substantiated by what I mentioned earlier, right? The diagnosis is always working diagnosis, right? If you feel like something is not going right, your gut feeling, right? Then you have to come back and revisit the question, say, oh, let's start over again without leading question. You could even say that, oh, I think I might have led you to some direction, but let's start over from the chief complaint all over again. Something like that. But that's an excellent point. But depend on the level of trainee, right? Okay. So I mentioned earlier that I don't think this tool is perfect, right? In fact, it was the purpose of the society, the team that I work with, not to make it perfect, right? Because that's why we chose to do rubric too. Because with the rubric and a lot of descriptor right here, no psychometrician could do inter-rater reliability or anything at all. For those of you that do all this psychometric evaluation, say, oh my goodness, this is a horrible tool, right? You did not create an instrument for me to do psychometric evaluation. That's because the primary reason for that is hidden on this slide. Anyone want to guess where's in this slide to say that why we decided not to create a perfect tool?
And I guess I think it's because the answer, the key answer is in the left side of the slide. It's assessment for learning. Yeah, I think it's maybe because this tool is you like to not treat like assessment, but it's for the learning, for the feedback that learners can know what is they stand at this time and they should improve in the future.
Excellent. For learner. And in fact, it's for teachers too. How so? Why is assessment for learning tool actually good for teacher?
Yeah, for in my opinion, I think maybe because we know that uh what we should provide the tailor-made development for our student. When we use this assessment, we know that what is dimension that our student weak and what is dimension that our student is strong, and we can design the learning for that particular student.
Very good. We need vocabulary. We need terminology to use, right? Who have a husband or wife that keeps saying, give me that thing, I want to do. I say, what thing, right? I say, that thing. What gonna be the consequence of that? They will get into a fight, right? I say, what that pink toad? It's actually the viral moment about the pink. Get me the pink toad. I said, what's the pink toad, right? Okay, anyway. Joking aside, that's why we purposefully created this assessment for learning. And that's why I put in the first slide saying for learning conversation. Okay. So what do I mean by learning conversation? If you could look at, this is the feedback. By the way, we have conducted a study using the clinical teacher to use this tool, the rubric, and ask about the struggle or barrier or something. If you're interested, go look at this slide or this article. It will give you a lesson on how you could optimize the use of this tool, okay? But in that article, we create this conceptual framework that learner have seen the patient and present the case to the attending physician or nursing supervisor, right? We then listen to them. The learner, what happened in the learner head would be, or what they want to learn. By the way, this put aside the patient care aspect, right? What I want to learn, create a plan, and then how trainee could improve. At the same time, the attending would listen, but everyone, especially for more experienced clinician, they already have their own way of thinking. right? So what we hope is that this ART framework and the tool could offer structure, terminology, the most where would be all the vocabulary to engage the feedback conversation, right? So we will not have those moments or give me that thing. You should do this thing and not that thing, right? It's very difficult. That's why I show at the beginning of the session the black box. People tend to get into the cannot develop at the bottom the share mental model, how a trainee is doing well on certain aspect, but not some others, right? That's why we want to create this as to structure the feedback conversation. I want to pause here for any question and comments. Yes.
Well, this is a good point because the assessment for learning is now very famous in medical education.
More famous than
according to the
Lisa.
like Lisa, yeah, like Lisa, programmatic assessment is very important, and it focuses on the assessment for learning and to improve the student progress by giving the feedback, mutual feedback. Just my pick up this point.
Great. What I understood, what you're hearing is that it's famous because it's a good thing, right? Because we won't do any educational approach or feedback just because they are famous, right? Yeah. But we also recognize that some people love assessment of learning, right? Especially as much as we want to use assessment to promote learning, at certain point we have to make decision. So we have, I don't have time to go into the fine detail, but if you go to this article, what happened to my QR code? But anyway, you probably could retrieve this article from medical teacher. We if you look into this assessment tool with 15 items, you would say the footprint from the original rubric, okay? But if we have formed the 5-point Likert scales, and we did do some validity evidence, collect some validity evidence to support the use. Again, it's not perfect, but actually it turned out to be better than I thought from the beginning. So for those of you that would like to, let's say at the end of rotation, we need to stamp something. I would say that this could be something that you could consider. But more importantly, as you pointed out, that programmatic assessment is so popular. But I'm not suggesting that would be this level can be called a programmatic assessment, program of assessment yet. But my recommendation would be, let's say if you have a 4-week or 6-week clinical rotation for trainees, you could use the ART, the rubric, as an assessment for learning and promote the learning conversation, giving feedback, and with multiple time though, right? So the collective learning conversation hopefully could help our trainee master some clinical reasoning skill to certain level, and then you could put a stamp on at the end of the rotation using the ARTR as a Likert scale instrument. So you could use that information and pass on to the next rotation. So the future rotations educator could have almost like the side off, right? That or there's certain area that this trainee should be working on, right? Any questions on this approach? If not,
I would like to know, like, because I think students have different level, like medical student, residency, or fellow. we could use the same tools, but how do we actually like set the expectation? Because if we use the same tool for different group of student, there might be like some confusing element because all the rubrics and everything are the same. What should we use this to hang on to, or what should be like the anchor behind this rubric?
Okay. Thank you for that question. There are some nuances there. That's why whenever after we publish this ART, actually I receive a lot of contact that people want to study. Every single time I say, let's talk about it, meaning they contact me to use the tool for their research, right? I would tell them, oh, you want to talk to me? Because there's some nuances. So you will not do the research incorrectly, right? Because we could not explain everything in the paper. So in fact, there's a lot of nuances in there. For example, one of them would be to address your question is that about multiple different level, right? I could tell you right now, problem representation sound easy, but actually it's very difficult for early training. So for early training, you might want to focus more on the first domain, right? For the problem representation, you might want to tell the trainee upfront. For example, for my residency training, right? I would say that for intern, the first year resident, I would not really think that they could go to the level 3 at all. If we use like a scale, probably in kind of the best intern would be in the middle, right? So for the fellow level, definitely they have to go on that, right? So you might want to focus on different domains for different level. So they would not feel like, oh, why you keep using this when I was intern? I'm not now a fellow, you're still using the same tool. I have not grown at all or something, right? I think we have to wrap up. Even though because of the interest of time, that's one reason. That's why I present only the ART, okay? But that's not the primary reason that I presented only the ART. Because even though I presented only the ART, I'm not saying that you should not use other tools. But I want to go back to my early point that if you want to use other tools, make sure that you have the same framework, right? Or multiple domains. So you could, let's say if you want to use the simulation tool or you want to use an oral examination, make sure that each assessment can be mapped and make it purposeful that you want to use oral examination to assess problem representation and data gathering, for example, right? Because otherwise, if you use all these tools randomly, at the end of the day, student will get confused. And the educator, if you sit into the clinical competency, you have CCC, right? Critical competency committee, people would talk about the same thing but use different languages, right? Analogy here would be there are multiple languages here. I don't speak Southern Thai. I speak English, so people from different countries could understand, right? For example, this is the paper that just got published. I'm not part of the authors, but I'm the deputy editor for Perspective on Medical Education, and the group have used the ART as a framework and create the OSCE tool for medical student assessment, right? So this is just an example that you could still use different tool and all that, but make sure that you have the same construct, okay? The most important, that's why you all are here, right? The most important thing about using any assessment tool is faculty development. For ART, actually have the video, animated video for faculty development, like 7 videos. Unfortunately, I don't know some of you that have you been to the Society to Improve Diagnosis website? When you use the ART, the society went bankrupt recently. So now all my videos gone. So I'm still contacting the society if I could start it somewhere else. But this MedEd portal actually have some slide and something for you to use and for your own faculty development. Okay, I'm gonna pause here and we went over time. We talk a lot already. Probably let's close it, right?
Okay. Everyone feeling a little bit refreshed? We will get out of here on time, so don't worry, don't worry. Well, thank you so much for the invitation to come this afternoon. It's an honor to be here at SHEE. We're going to shift the conversation a little bit now from clinical reasoning to assessing the values of an educational program, really through the lens of a community of practice. And I'm sure most of you have heard of the word community of practice. Many of you have been involved in community of practice. It's been a pretty popular term that's out there. And I think as Satid mentioned, words are very important. So before we go through and hear about each other's experiences about being involved in a community of practice, we'll go through and define, make sure we have the same understanding of what community of practice is. So just a disclosure about my involvement in an educational technology firm. It's not going to impact my content with you today, but disclosing that. And then there is a QR code here. I think it's not working in the room necessarily because it's distorted on the screen, but for those of you online, it should work. And it's a booklet of all of the resources that we have used within our work of community practice that you can access as well. So don't worry about taking notes. Everything is in this booklet for you. And for those of you in the room, we'll send that out afterwards to everyone. All right, so when we think about community of practice, it's used a lot, but sometimes it's not properly used. So what exactly do we mean by community of practice? There are 3 basic elements that you need to keep in mind. The primary one is the domain, and this is what really fixes a community. It's the shared interest that members have. And so membership in a community of practice means those members are committed to this area of interest. Secondly, the community refers to the people who are coming together. So they're interacting consistently, and through these activities, that's how the social learning occurs. And pretty importantly, they have to be practitioners. So through their practice, they're able to think about different ideas and put that into testing, and that forms the shared repertoire of that community of practice. So shared repertoire can be experiences, it can be tangible tools, guidelines, it can be the recurring challenges that people are facing and the solutions they come up with. So why is a community of practice so powerful? It's powerful because when members interact within activities, they create value. And here we're talking about the value of learning enabled by that community's networking and involvement. And I think this is really going to be the interesting part that we'll talk about in assessing the values of the different educational programs that you're a part of. All right, so Satid.
So this slide, we conceptualize this slide in order to give clarity around how community of practice can be formed at the different level and how it's can be situated at different level. If you look at the x-axis, is the represent the continuum of collaboration, right? If you normally you start by from the level of integration, collaborate. Integration meaning in pretty much in the same team, right? So it's not community of practice yet because you are working together as a job duty, right? And you start to collaborate with other people that's not in your the unit, direct unit, go all the way to cooperate, coexist, and perhaps you compete with other units, right? And the y-axis represent kind of the side, the landscape, right? Starting from just the program, department, institution, and the whole field of, let's say, medical education or healthcare, right? What we try to say here is that a single community of practice could be formed at the local level, but at the same time, when the community of practice become more mature, inherently or naturally, one community of practice tend to just start to connect with other community of practice. And if you go even further into the landscape of the whole field, there would be form a more and more network with other network, right? Why is this important? A lot of time when we talk about community of practice, we talk about social learning space in a single community. But what make community of practice powerful is also what they call boundary crossing. Meaning you see the dot here in that different level, right? When you cross boundary, start to connect with other community, learning in the metaphor would be cross pollination, right? You could enhance your own community even more. And a lot of time learning happen when there's cross pollination or boundary crossing, right?
Yeah, absolutely. So we would love to hear from you all what your experiences have been learning within a community of practice, whether formally called that a community of practice or based on what we've shared with the three elements that consist of a community of practice, an experience within a group like that.
In Thailand, we have a community that did quite well. It's called Thailand Education Partnership. They are a group of educators from around the country from different backgrounds, which they did quite well in tackling the country's educational issues. And I have to compliment them for doing such a good job and having a very engaging. I would say that it goes beyond the community now. It's more of a network. How engaging, I would say. Usually, the government or the Department of Education or the Department of Higher Education would throw them an issue, and then they would ask for volunteers, and then they basically throw us into a camp in some hotel for 2 days saying, you're not getting out of here until you solve this issue.
Excellent. Thank you for sharing that. And it sounds like what I heard from you is that the engagement piece was really important in how you see the success of this community, right? And so that's one critical piece of what helps a community of practice grow and sustain over time. It's that engagement piece. So that is one example of an activity that bubbles up within the practice. There's some challenge that's emerging, and because there's a group of members who are committed to the shared cause of improving education, they're then able to mobilize and be engaged within a common shared domain. Very good. And out of curiosity, is this medical education or like K through 12 education?
All of them.
All of them. Okay.
So you have
wow.
medical educators who are part of the community. You have kindergarten teachers.
Wow. And that is prime boundary crossing example. And I think that's another reason why it's been so successful, is because there are strengths from each different areas of education that we don't necessarily know about until we share that and access.
So I love the example too, but I want to highlight one thing that I agree that I think it's still community of practice, but it starts to grow beyond, right? One thing is that when you say that you sometimes you received a task and go camp out in the hotel, those group actually have become team or task force and not community of practice. So it's a good example that would be a task force that's almost like pop up from a
Within.
community of practice, right?
Who else would like to share an example of their involvement in a community of practice?
Are you community of practice here? Congratulations to Ajahn Chersak that everyone said this.
Yes, for those of you who may not know, Ajahn Chertsak presented how SHEE's community of practice has really grown over time, and I think that was the part that received the most enthusiasm from the audience. So there was great representation of SHEE at TMEC this week. Okay, so let's get back to this idea of value, right? How do we know that a community of practice is successful? How do we know that it's achieving what it's meant to do? Well, the value creation framework is one way that we can assess the values from the educational program. All right, metrics and values. I'd like to hear from the audience. What do you think metrics are, and what are some examples?
Pertaining to a program.
Yes,
Or a
an
community.
educational program. Mhm.
Who are collecting the number of participants today?
Was there a sign in? I know I had to sign in.
Sorry.
Okay, so that's one example of what a metric is, right? Attendance. The backgrounds of your attendees, your enrollment in the master's program here, the retention of students in your master's program. Metrics, you're very familiar with. These are the traditional widgets, we call them, that educational programs often collect. And they serve a purpose. They help describe and measure over time the characteristics of a program. But what about values? What do you think values are? Yes, okay, new ideas within the activities. Okay, yes, that would be a type of value. Yes, there's just lots of answers about values, and that's because values are fuzzy. They're more difficult to describe. They're complex, they're multidimensional, and they really depend on the perspectives and the goals of the different stakeholders who are involved in your educational programs. So, how have we conceptualized values? We've been borrowing work from Green and colleagues that define quality. And we think about values as the degree to which the program reflects its achievement of its intended purpose. Its demonstration of quality standards, its cost efficiency, and also its transformative change, okay? And even though values are fuzzy, it's actually really what matters at the end of the day, right? And that's why it's so hard sometimes to capture, but also why it's so important. And for me, the value creation framework really was the answer to help me explain why I could say, yes, this program really helped me, but before I couldn't explain why. It gave me a set of terminology and a framework to articulate that to my stakeholders, to the people who are paying my bills, who are, allowing the program to exist. So the value creation framework is a mixed methods framework that takes our traditional evaluations, which is called effects data. So these are the metrics we talked about, right? Your attendance, the characteristics, retention rate, satisfaction, learner satisfaction. And it incorporates contribution data, which are gathered through narratives from the participants of your program. And these contribution data, they're also called value creation stories. And it's a very specific genre of stories that is qualitative in nature and gives deeper depth of understanding of the effects on the effects of the interventions
Of the program.
of the program. So essentially, when you have indicators, you see the indicators, but you don't understand how they relate to the outcomes of your learners. And the value creation story establishes that causal link between attendance, for example, and then learning. So both of these together provide the values that then help explain value creation within a community of practice.
I want to see a show of hands for those of you that leading a program right now, or a team or unit, or aspire, Ajahn Chersak for sure, or aspire to lead the program. I assume that in the future you would have some research unit or something, right? So, right, you are leading a program, okay? So I ask this question because let's say Ajahn Chersak give you $1 million or 1 million baht to lead the program, right? And say you have to show me the metrics, number of your team in terms of number of publications. Those are metrics, right? But you know that you've been leading this unit for 5 years. You create a lot of values. But Ajahn Chersak just want the metrics. If you don't have that metric yet, right, because you have been farming, Ajahn Chersak might just say, okay, you no longer get my money, right? So what Diane trying to tell you, all of you, is that you need to be assertive, saying that, well, metric might take time. The return of investment might take time. I know that my people are creating value. My unit, my community are creating value. Let me show you what value we have been creating. That's what the contribution stories are all about, right? Yeah. Okay. It will rescue you for a few years. Yes.
Absolutely. Okay. So let's break this down a little bit more in terms of what are the values we're talking about. There's essentially 5 types of values. It's called cycle. Don't get hung up on that word so much. We'll get back to it. So at the top here, you see the 5 different values. Immediate value is the most basic one. Think about these are the action. What are your members doing? So what is activity, like this session? What type of interactions, maybe other webinars? Potential value refers to the things that have come out of your educational program or community. So this could be knowledge, this could be guidelines, this could be some protocol, this can be greater trust between 2 colleagues because of an interaction. Applied value refers to better ways of doing things, better practices. So perhaps there's a new innovation that has come about. In your paramedic community, you've thought about a better way to stabilize the patients en route to the hospital. Realized value is the benefit that the member or the organization has received because of some interaction or the community work. And then reframing value is kind of the harder one to think about, but this refers to the change that has come about and has helped the member rethink what it means to be successful, new aspirations, for example, new dreams. And these are some of the questions that we listed here that will help the members come up with the different indicators of value. When you ask these questions, this is what it will emerge. Satid, did you want to add anything? Okay. So some of these potential indicators are listed here, and I mentioned through the QR code, there's all of these tables, and more examples of indicators are listed there pertaining to educational programs. Okay, so I would like to ask you.
Dan, would you mind
Yes.
going back to those slides and maybe pause a little bit and see if, for those of you that have probably evaluate your own program, your own unit, your own work, or might be doing in the future, anything jump out to you?
Does
or
it make
any question
sense,
or
or
comment so far?
would you change anything? Would you add anything?
I don't know if it is like similar, but after looking at those value, the one that pop up in my mind is like the Kirkpatrick model, like because of the evaluation, and it looks like that to me, except the refraining value. Yeah.
Yeah, good point.
Just delete Kirkpatrick out. Yeah.
So definitely Kirkpatrick's kind of layers in to the value creation cycles as well. And I would say, yeah, so they all align. And I think maybe the reframing value is what is not quite inside the Kirkpatrick's.
So when Wenger and his team formed this value creation framework, actually it was informed by Kirkpatrick. Okay, but Kirkpatrick talked about multiple levels, right, of evaluating an educational program or intervention, but without giving any guidance in terms of how we should go after that as a mixed method. Okay, one thing that you all need to be aware about Kirkpatrick is that a lot of time we see Kirkpatrick evaluation model in the literature. It would be is a pyramid, right? You like pyramid? Anyone went to Egypt? For one thing you need to know about health profession education, okay? Anything that have been illustrated as a pyramid has been debunked. So what do I mean by being debunked? Are you shaking your head? You want to answer my question about why it should not be a pyramid?
I nod the head because I see a lot of these getting debunked paper, like learning style and everything. But for me, the pyramid is kind of like you put something at the top of hierarchy that is the best. For example, like systematic review is at the top, but systematic review of a bad article is not the top of the pyramid. So also like the assessment, if your assessment like DAS level or Kirkpatrick level action, but is not the best way, or is not captured with the best tool, with the best person, with the best practice, that also not on the top of the pyramid. It's also like on the bottom.
Very good. That's an excellent point, that whatever the pyramid in health profession education, at the tip is not always the best thing. That's one point. But particularly for Kirkpatrick, actually they are not levels at all. Kirkpatricks are just different types in terms of the domain for evaluation, right? I see a lot of shaking head now. Probably you have read or thought about that, right? But we still have the tendency to say it's Kirkpatrick level 1, 2, 3, 4. Okay, so And this also was distinguished Kirkpatrick from value creation, that as Diane pointed out, there are cycles, right? If you check, how many of you have read the New World Kirkpatrick? Google New World Kirkpatrick. It's no longer a pyramid, okay? So just a tip for you, if you want to create any model or framework for medical education, don't you dare to use a pyramid, because someone's gonna try to collapse your pyramid. Anyway, so that's a sidetrack a little bit, but very important. So the key feature for value creation framework is that they are not level, and they also inherently require you to conduct a mixed method.
Mm-hmm. So I don't have the image that shows kind of how the value creation stories relate to your traditional effects, so your metrics, but I'll try to explain it here. So the metrics can fall in any of these value buckets, okay? Usually they will fall in immediate, potential, or applied. So let's say a new tool was developed, or the number of publications, that was the example. That would go under productive activities, for example, immediate value of the actual publication. But the group of people that got together within the community of practice to work on that, they were able to get together and leverage that new relationship to make that publication. And that falls into the potential value of their new social trust, new relationships. And then let's say they were working on a paper that was focused on an innovation in practice. That innovation can be qualified as applied value. So you see, it's like one aspect, we're talking about a publication, but it spans 3 different values. But you don't get that just by saying, we've gotten one publication from this group, right? You don't know that. You would find that out through the value creation story, by getting the narrative from that member or these 2 members. And so those stories will connect one publication across different values. And that's why cycle is the word that describes it.
So go back to your example that I say, oh, you're going to be big boss in the future, right? If Ajahn Chersak want you to have 20 publication in 5 years of under your leadership, right? It's difficult, right? But you could say, Ajahn Chersak, I have only 7 publications, but there's a lot of other values have been created through those 5 publications, right?
Exactly. And that also underlines another aspect about community of practice, is that the community of practice is not like a task force that's supposed to solve a problem necessarily, or a team that's supposed to produce a publication only. It's a matter of improving capability of a group of people or individuals. And so this value is like, okay, I only have 7 publications, but look at the value from what we've been able to do together. There are more people now talking to each other and collaborating. That's potential for more publications in the future. So that's a very important part to think about. Community of practice is about improving capability within a group of people. Okay. Yeah, so I would like you to think about the programs that you either lead or you're part of, and think about, maybe immediate value is kind of obvious, but think about potential, applied, realized, or reframing value, and reflect on 1 or 2 indicators from your experience within this community of practice. And if it's not an official community of practice, think about a group of people that you've been refining your practice through continuous interaction. And if there's
Maybe
any brave school.
Maybe do in pair. Yeah. Help each other. Let's see.
Yes. So
5
think about
minutes?
it. Mhm.
5
We'll take
minutes?
5 minutes, think about it, and then turn to your neighbor. Okay. There was a lot of conversation. So we'd like to hear from some of the groups about your reflections on your experiences and what indicators of value you have seen.
Just want to like moderate. There is like a group of like senior faculty community of practice in the middle and young staff at the end of the room, and master degree student community of practice internship and teaching assistant community of practice. So you can have like see the
Yes.
So
relationship.
you're sitting as tribes, different tribes.
We're going to try to cross-pollinate through the next few minutes of sharing here. Which community would like to go first? The staff community?
Supporting staff community.
You all are some of the most important communities. You make everything work. So
ถ้าคุณค่าของงานชีเราในมุมของบุคลากรที่ทำในชีนะคะ เรามองว่าเราได้พัฒนาคนทั้งในศิริราชแล้วก็คนทั้งประเทศด้วยอะค่ะในส่วนของการพัฒนาค่ะ
Okay, in the SHEE perspective, we did not only create value for institutional level, but we also expand our value to like international and national level. That is something that they're proud of and seeing media.
Wonderful.
And we're not the first step for practice the student, but we support teacher in the second step. But I think the second step is very important if we are work is the best. So the power of the second step of working with push the first step, and the teacher but push up the student again.
Okay, to clarify her points, she tried to tell us that we not only teach students, but we teach teacher, and because we improve the quality of teacher, and that those teachers, they improve the quality of students in chain. Okay.
Thank you. That's why Diane said that your work so powerful. Yeah.
absolutely. So I think what I heard from this was there was potential value when you're supporting the teachers as well. That's increasing the value of their ability to then support the students. So very good.
Precisely.
Very good. Who else would like to share? Yes, yes,
Oh,
yes.
very enthusiastic tribe here.
Actually, we choose our own program of health science education. So we are international. We are international program, and so our metric is the number of students per year, the graduate rate students per year, and employment rate after graduation, and our publications and the offering of the scholarship in this program. So our values might be more of them are immediate to the reframing values, because we are the international program and we have the social networking in this participant, not only the students but also the faculty members, among the Thai students, and also agents as well from another countries, and that's why. And after we graduation, we can produce many students who are very excellent, and they can apply this new knowledge into their clinical practice. And so our values is this one is very important, because we can produce many students around the world and around the country, and we can yeah and we can do the innovative learning, getting from the knowledge to applying in our own country. And so our own university can be reputation in our country, and so the organization can change in our own country.
Thank you so much for sharing that. It appeared to me that pretty much you got all the cycles captured, right? But I want to reflect on just the way you report out your conversation with enthusiasm. That's the need. I would say that's the most beneficial aspect of using value creation framework, actually, because it's more intuitive, and also more powerful and meaningful for you to tell the stories about that rather than fixating on just specific numbers, right? Thank you for your insight. Dan?
All right, do we have, yeah, we have some time left for another group to share.
May I share about my experience? For the first immediate value, I would like to interpret with my emergency nursing and emergency medicine. And I joined to the emergency nursing after the SHEE game in Myanmar. So it's very famous, and so I interested and I joined this program. And then in potential value, I learned a lot, not only knowledge but also the skills and so many things. Then and then I joined to the educator. And I work as a nurse, emergency nurse educator, and with how can I say, I invited my friends to join with this program. So we both of us lead the program, and then we have heard about our reputation of emergency nursing development. And then at that time we collaborate with emergency medicine together in the emergency nursing and medicine education. And then for the realized value, to be honest, emergency medicine is very reputation in our country. And then we have to collaborate with the Australia Alfred Hospital trauma team, and then we go together and then we learn together. And then in 2019 we went to the Japan and for the disaster and emergency development. So we work together like a team. And also, and then in 2019, after coming back, we offer the training, and then we have the emergency medicine lead the first Myanmar emergency medicine conference. That, and then we have many vision and many value from the nursing aspect and medicine aspect. And then we have many schedule to move forward and development in emergency medicine in Myanmar. This is my example.
These are such amazingly strong examples, and I have to say I'm impressed by the caliber of experiences and expertise in this room. So, and it's great that you've been crossing boundaries geographically as well, you know, throughout the region. And so, thank you for sharing that experience. All right. What other comments or questions do you have? I think we're kind of, yes, Dr.
Okay,
Tritza.
I want to add something, and that might link clarify things that the students of the program and the people who work for SHEE may understand it a little bit better. I want to link this with the vocabulary that I usually teach at SHEE programs. I may not use the word metrics and the word value, but the words that I usually use to communicate with you is between achievement and success. Achievement is the achieve of the various KPI, and it will link to what you are hearing today about metrics. But I also emphasize the need that we have to look for the success, and success is the value that we are talking about today. And what we are trying to see in the success of our organization or our unit is whether we answer the purpose of our unit or not. And sometimes the success cannot be measured just yet. Professor Satid has mentioned that it will be something that you don't need a lot of time to measure in the long run, like return of investment. It may take years. But I want to add that sometime in the long run, what matters is actually the values, something that you cannot measure today. But if you actually achieve something that is truly respond to your purpose, and those are the things that many of us were forced by me to do. You may think, okay, we do a lot of things that the university doesn't measure, the faculty of medicine doesn't measure. Why do I have to do these things? It doesn't go into any report. It doesn't go into any KPI. But I would say that those things are new aspirations, new values creation. We do many things that doesn't measure out in numbers, but we reach out to other community. We reach out to other hospital. We help the society in the ways that cannot be measured. And I think those things are in the 5 cycles of value of creation, and it will help the survival of the organization in the long run, more than just metrics, just the number of course we have to measure in numbers. We have to report to the organization about the number of application, the return of investment, whether we get profit or not. Those are things that we have still to collect. But I want you to think based on this talk that we also have to care about values, things that cannot be measured just yet as well.
Thank you so much. I could not articulate better. It's very, very critical, right? One thing, if I may add, would be those value, long-term value, or the value are being created for long-term success, actually fit into the achievement too. All the metric, all the numbers would get better if you also pay attention to value being created, right?
And that's why it's a cycle, because it can go either way. These values feed into metrics and vice versa. And so I've just in the little time that I've gotten to know SHEE through Dr. Chertsak, I am very impressed by the level and the caliber of this center's work. We would love to help you capture and articulate the values that you all are doing. So if you are interested in using this to better convey the story of your impact, reach out to us. We would love to work with you on that. Okay, so I think the next slide is just another invitation to collaborate in the future. We have evolved our community of practice into a network of practice that focuses on health sciences scholarship. And this movement, this international movement has been burgeoning through most of Sub-Saharan Africa and Latin America, and now has expanded into regions of Southeast Asia with our inaugural members, including Dr. Chertsak, representing SHEE. So come check us out, and we would love to have the different communities of practice already in the room join this movement. And if there are activities that resonate with you, you are welcome to participate and get to know other educators around the world. So thank you very much for having us.
I really enjoyed this session. Thank you. Both sessions, actually.
On behalf of Siriraj Health Science Education Excellence Center, Dr. Prab and I, we would like to thank Associate Professor Satid Thammasitboon and also Associate Professor Diane Nguyen for your valuable time sharing your experience with participants from the Faculty of Medicine, Siriraj Hospital. And I already checked about the name of the participant. We already have some participants from Cambodia as well today, and also from another universities in Thailand. So we hope that in the future we may have a chance to collaborate some kind of the workshop or some kind of the collaboration again in the future. Thank you very much for today. Ajahn Chertsak, would you like to say something before we gonna finish?
Oh, you already closed it very well. Okay, I just want to say thank you to Dr. Satid and Diane very much for coming to share your experience with us. Thank you.
And for participants, please give us your feedback through the links and QR code provided after this. And also, you can join the The next hybrid topic of post in medical education, which is the arts of listening for medical teacher by Dr. Sorayut Ratana Pochanat. Next time on April, the 9th of the April 2025. Until the next time, thank you very much.